Greetings. This is Graham working with you on the HipOp case study optimization tool. So what we have in front of us, obviously, is the basic simulation model, and we have all these parameters here that you can edit in simulation main, and um, the setup here, in fact, is not the originals, but you can edit them and run the model. So what I want to talk now about is sort of like automatically configuring these various settings, the number of surgeons, number of anesthesiologists and whatnot in a systematic way using some kind of an optimization strategy. So to do that, we click on optimization main, typically be around about where simulation main lives. I'm going to click on that and then expand this a little bit here and just go through what's entailed here. So essentially what we have at base here is some sort of objective function along with some constraints. We can either maximize or minimize the objective function. And I'm going to sort of give you, there's a bunch of language in here which refers to variables in the model. So for example, root.surgeries_A is sort of the finishing value of the surgery count for surgeries in track A, and similarly for B. And then numsurgeons underscore track A would be, that parameter that we set for, however many surgeons we dedicate to track A, orthopedic surgeons. So in the early going, when this case was first written with Paul Kanoja and Julie Katie Ray, Paul articulated a concern. He was director of orthopedic surgery in his workflow. And he was concerned that they were getting about 4 or 5 completions per day per surgeon. Obviously, residents are involved, and there's an educational piece to it. But he noted at that time, this would have been approximately 3 years ago, that in private practice, folks were getting up to 8 surgeries per day. So I was concerned that they were, at about half of that. Now, in the twist for the case this term, Paul is, concerned about pivoting on the on the objective. In the past, there was this concern about patient flow times, excuse me, and the surgery count, getting up to 6 and hopefully beyond. But now Paul wants to move more in the direction of the triple bottom line, which recall factors profit, people, and planet. So planet is a little mute here. Obviously, there would be sustainability issues around consumables and and other components used in the surgery, power sources and whatnot. But our primary concerns here are with profit and people. And so there are some links in the case in the assignment document to recent publications on burnout among orthopedic surgeons and residents, and that this is an increasing phenomenon. And so Paul's interested in exploring a triple bottom line approach and to sort of like verify whether solutions to his problem, to his operational assignments, staffing and OR assignments and allocations and whatnot, actually are recognizing appropriately profit and people objectives. So with that in mind, we've got an optimization tool here that has an objective function. I'm going to just sort of spell out loosely for you what is entailed here. So the very first term is the revenue term, which looks at the number of surgeries per day and multiplies that by 200 for 200 operating days in the year, multiplied by $22,000 per surgery. And then from that, we're subtracting salaries for the surgeons. And you can come in and you can revise these numbers, but currently they're thought to be earning $650,000 a year. The physician's assistants, $200K, anesthesiologists, $393. And then 60,000 for the registrar, 60,000 for the EVS pool folks. Just need to move my window around here. 200 for the CRNAs. And then interestingly, also deducting $20,000, sort of a one-time deal for every flow time minute that patients wait in either track, so in track A and track B. So both of those get $20,000 penalties. So we understand that longer waits, are anxiety provoking and uncomfortable for friends and family and the patient. And so we're looking to minimize those at a minimum to improve patient well-being. So that's a component factored in here. What's not factored in here is anything to do with burnout of surgeons. So whether that's an issue in the final design as it emerges is a question for you to consider. All right, so we are going to do 500 fixed iterations here because we have the free version, and I think that we're limited to that. And we have a bunch of parameters here. I want to just explain what's entailed here. So you can see that some of them are fixed, but then some of them are discrete and have sort of ranges that they can be varied. And so the idea is that this tool is going to come in and try literally every combination as expressed by these various limitations. So, for example, the number of anesthesiologists in track A is going to be varied between 0 and 2, sort of one at a time. So it's going to try 0 and 1 and 2 among all of the other sort of simultaneous changes. So you can imagine that there's dozens and dozens and maybe even hundreds of different parameter combinations potentially. If you had large ranges for these items. So we're going to vary the number of anesthesiologists in track A and B, the number of surgeons in track A and B. They only go from 1 to 2 because we must have 1 by design, okay, dedicated to track A and B. And then the ORs vary between 0 and 2 because we're relying on the multi pool if you so choose. Can't change the total number that's fixed at 4, but you can choose to put them all in the pool or dedicate 1 or 2 to each of the tracks. All right, so that's true for these two number ORs for track A and B. The EVS pool, you can have 1 or 2. And then down here for the number of registrars, you're going to have 1 or 2 for the number of ORs in the pool, anywhere from 0 to 4. In the CRNA pool, we're allowing you to add up to 4. And also in the physician's assistants pool, also from anywhere from 0 to 4. All right, so that's how it's going to change the values. We also have sort of a good model time for a minute. This expresses how long our day goes. So it goes from 7:30 to 6 p.m. So that's 10.5 hours. So that's 630 minutes. So it gets automatically terminated at that point, and it makes its assessments of surgery counts and so forth at that time, and it does its computation of the profit, which is essentially what we have in this objective function, right? Now, there are a few other things to note here. The constraints that are presented. First is that the total staffing count has to come in under 11. So in the base case, it's 8. You've got 2 registrars, 2 anesthesiologists, 2 surgeons, 2 VS pool staff members. You can reduce registrars, you can reduce EVS folks. You probably can't reduce the anesthesiologists, but you don't have to dedicate anesthesiologists to the tracks. You do have to dedicate surgeons, 1 surgeon to each track, but you could put PAs in there as well. So bottom line is the net increase of 3 is all that you can add. And so the total count is to be 11 or less. And then we're requiring that you have an anesthesiologist or a CRNA per a track, that the number of dedicated surgeons in track A is at least 1, and same for B. And then also making sure that the number of anesthesiologists in track B is at least 1, CRNAs and anesthesiologists. The number of ORs assigned to track A, either in the pool or dedicated, is 2 or greater. That's true for both tracks. And then the total number of ORs is equal to 4, and the number of Yeah, and I think that basically sums it up. Okay, we are running this 10 times, 10 replications to make our assessments. And I'm going to go ahead and run it. There's one other point here, I think, worth noting is that you've got a couple of tools here, OptQuest and Genetic. This is a heuristic optimization environment. And in fact, I'll run this twice for you just to see if we get the same result. So it's not, guaranteeing an optimal decision. It's going to give us a robust solution, one that's hopefully near optimal, but it can get stuck in local optima. So just bear that in mind. So let's run this guy. When you run it, you actually have to be careful to run the optimization. So let's go and run that. Now it's going to, try a bunch of, first it's going to pop up a window here, hopefully. This time, let's try again. Here we go. Okay, so it's waiting for us to hit start. What it's going to do here is it's going to try a bunch of different solutions. It'll record the best. It'll give us some sort of graphic display showing what the profit looks like. And of course, we're maximizing. So we're expecting, our best solution to sort of increase over time. And these ones in blue here are the parameters that the model is changing. And then the ones in black are fixed, right? So like the arrival timing is fixed and the registration mean and standard deviation are fixed, and so is the sedation and so forth. You could experiment with changes with those. Happy to talk you through those. All right, so those are the changes. Let's go ahead and run this and just see what it's doing. Okay, so you can see it's trying a bunch of solutions. The best solution currently is a $37 million, almost $38 million solution. I only had to do a handful of different parameter checks because there's not an endless number of things you can do, mostly because you're so contained with those ranges, right? Of what the parameters, how they can vary. Let's see what's entailed here in the optimal solution. So it wants 2 dedicated anesthesiologists for track A, 2 for B, wants 2 surgeons in A, but only 1 in B. Dedicating an OR each to track A and B. It's firing one of the EVS people. It's firing one of the registrars, we're down to 1 now. And then it's putting 2 ORs in the pool. So there's 1 dedicated each to track A and B, and then there's 2 that are pooled. No CRNAs, no PAs. So let's do our count of staff members here. Remember, we're limited to 11, right? So 2, 4, 6, 7, 8, 9. Okay, so we only have 9 staff members. So we're allowed 11, but we're only choosing to hire 9. And the reason for this is, these folks cost money, right? So that's payroll. So what it's doing is it's evaluating and saying, probably can get the same surgery counts with a count of 9. And if they did add the others, we'd just be paying them payroll, but we might not get the extra surgery counts. So that's why it's ending up shy of 11. All right, now you can copy these over, and you need to estimate the performance of the system with these new settings. Well, we'll do that in just a second. I just want to try to run this thing one more time for you. So I'm going to stop this and then rerun it. Let's try it again. Stop it and rerun it. It's 39,404 there. Let's just see if there are any changes. It does. 37, 734. So it's giving us a different solution. And you can see how now it's not assigning any anesthesiologist to track A. 2 are going to B, 2 are going to A, 1 is going to B. Again, we're only 1 EVS person, 1 registrar. Now we've got 2 CRNA pool people, okay? And so let's get our count. So 2, 4, 5, 6, 7, 8, 9, no PA. So again, 9. And this one comes in at 37.7 profit. All right, now let's see how we would go and estimate the performance. So we have to allow this. Just basically copying this to the clipboard. Close this out, go into my simulation main, simulation main. You can see there's a paste from clipboard here, so I'll just paste that in there. You can see all my parameters appropriately says 0, 2, 2, according to what I've just done. And I can go ahead and run this. Now, again, you have to be careful to just select the simulation when you're running the simulation as opposed to the optimization. And you know, I would build a confidence interval from this. I'm going to just run it to completion. But let's just see what I got. So I'm getting 6 completions here, 5 here, and the flow times are 155 and 68. I'll stop that and just rerun it. So now I've got 2, 4, 5 here, 150, 173. This is a workflow with a lot of variability, and communicating the variability to Paul or to your decision maker is going to be key. So that's why I'm suggesting confidence intervals as opposed to just saying the average value is 4 or 5 or whatever, 6. So you got 6 here and you got 5 here. Flow times are about even here, 159. But the point is that there's a lot of variability, and we do want to communicate that somehow. So I don't absolutely need a confidence interval here, but something like standard deviation and a mean maybe enough. All right, so we've got the profit maximized, within the context of the heuristic optimization. And what remains for you to decide is whether you're okay with the patient experience and the provider experience. So I'm hoping that this sort of optimization piece is an interesting extension on what we had for the previous case. And our work in the case is particularly focused on whether this tool could function as a digital twin for Paul Kunijian. Enjoy.